Good afternoon and welcome to everybody. My name is Lagacé Dowson. I'm the host of the webinar and the communications director of the Canadian Health Coalition, which was founded in 1979 to protect and advance healthcare. The members of the coalition include frontline healthcare workers, civil society groups, researchers, students, faith-based groups, and individuals who are committed to public universal healthcare in Canada. I'm speaking to you today from Tiohtià:ke, or Montreal, on the unceded territory of the Kanien'kehá:ka of the Haudenosaunee, the Mohawks of the Six Nations Federation. So, bienvenue à toutes et à tous. Ce webinaire se déroulera en anglais, mais nous pourrons prendre des questions en français dans le Q&A. And I'd invite you to put your questions and comments in the Q&A, and we'll try and get to them throughout the next hour or so. So today's webinar is entitled Healthcare Challenges in Canada and Opportunities for Federal Leadership, a special election webinar with Dr. Danielle Martin. Our speaker today, of course, you may have seen her on screen already, is Dr. Danielle Martin, chair of the Department of Family and Community Medicine at the University of Toronto, an active family physician whose clinical work ranges from family medicine in rural and remote communities to maternity care. She's also the founder of an organization that we very much appreciate, the Canadian Doctors for Medicare, which she started in 2006. So it will soon be 20 years old. And we congratulate her and them. Melanie Béchard sent her regards, Dr. Martin. So in September of 2017, Dr. Danielle Martin went to Capitol Hill and spoke in support of Senator Bernie Sanders' Medicare for All bill. And in 2014, she appeared at a U.S. Senate committee investigation on healthcare systems regarding issues such as single-payer and multi-payer systems. The videos of those presentations have been viewed tens of millions of times. The last time I checked, it was 30 million. So Dr. Martin is truly a rock star on the healthcare file, and I'm very, very happy to speak to you today. So welcome to this webinar, Dr. Martin.
Thanks so much, merci, and thank you, Anne, and thank you to the Canadian Health Coalition for all of the really important work that you do. As a Canadian, I'm very grateful for the advocacy that the Health Coalition does every day. So thanks for your work, and hello to everyone from my office here in downtown Toronto and on the traditional territories of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit, among many other nations.
So, Dr. Martin, I just want to start with this. Why do you think so many people have watched those videos? Like, what is going on there when those numbers register online like that?
Oh, it's funny because I vividly remember coming home from Washington that night and arriving in my kitchen, and my partner said, how'd it go? And I said, I think it was good. It's too bad no one's ever going to see it but my mom, and the next day it kind of exploded, and I had this very bizarre experience of what it feels like to go viral on the internet. It's an odd experience. But it clearly at that moment tapped into something mostly for Canadians. This sense of pride that we have about our healthcare system, which is really a code for pride in our values, and this notion that we take care of one another, the commitment to the value that access to healthcare should be based on need, not ability to pay, and the extent to which Canadians have always and continue to see this as a differentiator between our values and the U.S., those of the U.S. writ large, in spite of its deep imperfections. And we all know that there are lots of things about our healthcare systems in Canada that need to be improved. Many inequities, many injustices, many frustrations, and yet we wouldn't trade it because we wouldn't trade those values. The fact that it has touched a nerve again now, more than 10 years later, I think is about something slightly different. It seems to be, circulating much more in American social media. And I think that part of that is our many friends, colleagues, family members, collaborators, sisters and brothers south of the border who need to feel some hope to hold on to in a moment where it must, at some level, be easy to feel lonely in your own country. And I think that, so it is funny to find, I'm getting these messages again. Oh, you did a great job at the US Senate. And I'm like, that's 11 years ago. That is a very old video. I'm forever young on the internet, but it is, and so there is something about the pushing back, and that at the time sort of polite Canadian way of holding our ground that is speaking to people again in this moment.
One of the things that you did was you made a joke about how a Canadian is an American, a polite American, but who has health care or something to that effect. Like in many ways, we are so similar to our neighbors to the south. But one of the main, and maybe even the main thing that differentiates us from the US is the fact that we have universal single payer health care. That doesn't seem like that big a deal, but it is a very big deal, as you so well define on those videos.
Well, and we've been, we've taken great pains in our trade agreements, these same trade agreements that we're seeing, ripped up in this moment, to try to do what we can to protect that differentiator. Trying to exempt the so-called markets for healthcare from transnational and international trade agreements. With good reason, because once we open the doors of our healthcare systems to investor-owned for-profit interests from other countries, whether the US or elsewhere, it's going to be very difficult for us to maintain our commitment to those fundamental values.
So one of the things that we did as the coalition is we went up onto the Hill yesterday to the Parliamentary Press Gallery to hold a news conference with our allies who work in women's reproductive health. So the Society of Obstetricians and Gynecologists of Canada and Action Canada, which is the organization that replaced Planned Parenthood, to say, we really, really, really feel the lack of discussion around healthcare, the lack of debate around healthcare in this current campaign. And then just as we were leaving the news conference, we were informed that healthcare will not be on the agenda of the leaders' debates on Wednesday and Thursday nights in Montreal. There's no mention of it. There's, a number of other topics, but not healthcare, which is a first, I think, for federal election campaign, where you almost always talk about healthcare. And I wonder, what is your reaction to that news, that it's not going to be on the agenda?
I mean, of course, as a family doctor, I'm disappointed. I wish that we could be spending our time talking about access to family medicine and primary care for every resident of Canada. I wish we could be talking about pharmacare, dental care, home and long-term care, how we're going to support a healthcare workforce in light of an aging population, et cetera. Like, there are lots of topics we could be talking about that relate to healthcare. But I also think, that we should acknowledge that we are in a very particular political moment, and that the issues that will be discussed in the debate this week are also health issues. If we can't figure out our economic sovereignty and ensure that life is affordable for people, there will be very direct impact on health. When people can't afford housing, when they can't pay their rent, when there isn't affordable housing available, when they can't afford, the chicken at the grocery store, et cetera. Like, these are very real. These are all the topics that will be discussed at the debate, really boil down to the economic and social determinants of health. So I don't think that we should feed the ground of, oh, well, there's no health conversation happening in the debates. Ultimately, the healthcare system is a very downstream set of interventions aimed at trying to right those wrongs or those imbalances that happen when we don't provide equity at the root, at the source of health, which is all of the social determinants that will be talked about. So yes, on the one hand, I'm disappointed, and also on the other hand, we all feel the particularity of this moment. And I think that we need to acknowledge that the things that will be discussed will have a direct impact on the health of Canadians, and we need to think about them in that way.
So the list of topics that are going to be discussed are affordability, energy and climate, leading in a crisis, public safety and security, tariffs and threats to Canada. So you're quite right. I mean, it's quite possible and likely that healthcare will come up under affordability, public safety and security. I mean,
I mean, all of them, in fact, and
sure.
The World Health Organization has named climate change as the #1 threat to health in this generation. So I don't think that I don't think we're not talking about health this week, but it is true that it would be better if we could also, in addition to those topics, be talking about who's going to protect the Canada Health Act, who's going to expand publicly funded services, who's going to push back against privatization of our systems, and who's going to expand the much needed programs that we have only just begun to dip our toes in the waters of, namely pharmacare and dental care. Those are it would have been great to see those on the agenda for the leaders' debate.
Right. And when you talk about the Canada Health Act, we also have to talk about the Canada Health Transfer, which was between 2023 and 2024, $49 billion of Canadian taxpayers' money, plus top-ups in the hundreds of millions. So the role of the federal government in healthcare is really important. And there are people who like to say, well, it's provincial, it's territorial. What's the federal government doing in this area? And every once in a while, we'll get a comment to that effect on some of our social media. And I wonder if you could tackle what you see as the role of the federal government with regard.
Well, I mean, it's interesting because I think that to some extent, Canada did drink this Kool-Aid in the years of the Stephen Harper government, that somehow the role of the federal government, if it had any role at all in healthcare, is to write a check to the provinces and territories and let the provinces and territories figure out what to do with it. But in fact, the federal government has a huge role to play, dating back to before the Canada Health Act, starting with the fact that Medicare is a core part of Canadian identity, and so acknowledging the nation-building nature of that set of public services, I think, is really important. The federal government, of course, provides healthcare services directly to particular populations in Canada, including Indigenous people on reserve, including the armed forces, et cetera, but also sets the agenda for reform in healthcare services across the country. And the pharmacare debate is an excellent example of that. There is no universe in which it makes sense to try to deal with the unaffordability of prescription medications, province by province and territory by territory. These are questions that demand federal intervention, that demand a national or pan-Canadian approach, whether we're talking about the ways in which drugs are approved, the ways in which the prices for those medications are set, or whether we're talking about ensuring universal access to coverage. And we find ourselves in this situation now where we began to implement the teeniest, tiniest version of pharmacare you can possibly imagine in this country. And so far, we've got 3 provinces and 1 territory who've signed on to provide universal access to essentially 2 groups of prescription medications, contraception and diabetes medications, and that's it. So even that is it's a small beginning, an important one, but a very small beginning. And it would be it would be a shame to stop here. And I think one of the things that we're all going to need to think about as advocates for public health care in this country is, never mind just the election and the next 14 days, 13 days, but what happens after that? How will we maintain these important questions of health and healthcare at the top of the federal agenda in a time when we are being sort of buffeted about by the political winds of what's happening with the Trump government south of the border? It's going to be a really tough one unless we can articulate for Canada, for Canadians, and for our government that this nation building set of programs is one of the ways in which we stand up for ourselves. All of this elbows out conversation about what it means to be Canadian and how we protect our sovereignty. One of the most important ways that we do that is not just by being in a defense mode, but by going on the offense and building the kinds of health and social programs that we want to be, that we need in order to feel proud and to have some justification for our pride in what it means to be Canadian.
And I note that Bernie Sanders, with whom you appeared and with whom you worked in both cases when you participated in those, what made you viral on the internet, those events. Bernie Sanders is on the road now doing a series of talks and presentations, and he's getting enormous turnouts from people who aren't the usual suspects. Like it looks like what you're saying is actually coming true, that a lot of people are now galvanized into action in a way that we haven't seen before. And I suspect that's also happening in Canada, because Charlie Angus is doing something similar. He's going on this Elbows Up tour, not specifically talking about healthcare, but just the importance of defending Canadian values and Canada itself. So you're right, after the election, a lot of dust is going to settle and we're going to have to figure out what to do. And I wonder, you're clearly a very powerful tribune for many of these issues. I wonder how you see yourself in that landscape.
Mm. Oh, I mean, I welcome the personal question. I wish I had a clear answer to it. I mean, I find myself here as a family doctor in the middle of the biggest crisis in access to primary care probably ever in the history of organized healthcare systems in this country. And I feel pretty compelled to be doing something about that. You know, if we've got somewhere in the neighborhood of 6.5 million people in this country who do not have a family doctor or a nurse practitioner or a primary care team of any kind. And, you know, primary care isn't just the doorway to all other healthcare services, although it is that. Primary care is where most healthcare services are delivered. Most people don't ever need to, happily, for most of their lives and most of the days of their year, to be admitted to a hospital or to go to an emergency department or to be referred to a specialist or to have an MRI or to have a joint replaced. Most of us don't need those services most of the time, but all of us need to catch things early, to manage our chronic diseases, to have a place where we can go to get our kids immunized, to talk about our mental health, to deal with our day-to-day aches and pains and twisted ankles and health crises in all of their forms. And almost all of that care is delivered in the community, close to home, in the offices of family docs, nurses, nurse practitioners, primary care teams. So, like, if we can't fix that, there is no possible way to build enough hospitals, enough long-term care facilities, enough emergency departments, buy enough machines to make up for an absence of that foundation. And this, I think, must be taken up by the federal government, as well as every government of every province and territory. And in fact, also at the municipal level, there's a lot the municipal governments can be doing, and not just governments, but all kinds of other civil society organizations. So I would say, I think I see myself there, you know, as a family doc, talking about why primary care matters, the reality that healthcare systems that are built on a strong foundation of primary care deliver better health outcomes more equitably and at lower cost than healthcare systems that do not. And so we have to fix that first. And I think that because it is my daily experience as someone working in family medicine, seeing the frustration of people who can't access the services and feeling the pressure of having inadequate capacity to deal with the needs and the demands in the system, I kind of feel like that's where I'm meant to be right now, is to be talking about that.
And in your book, you actually say some of this. You outline a list of things that need to be done. The book came out in 2018. It's called Better Now, and you have in it 6 big ideas to make healthcare achievable and affordable. And number 4 is strengthening primary care, as you just mentioned. But there's also right at the top of the list a national drug program instead of the piecemeal provincial pattern of buying drugs. So right at the top, you bring in pharmacare. And then we need to change the way we deliver care. Patients also need a regular GP instead of overusing hospital emergency clinics. We need to reduce unnecessary tests, strengthening primary care, creating a guaranteed income program, because poverty is the greatest predictor of ill health. So a guaranteed income could prevent and alleviate many health problems. So you're talking about the social determinants of health there, and scaling up successful innovation, presumably, so doctors don't have to send faxes to pharmacies and that kind of thing, which is what goes on in my neighborhood.
Just for example,
Yeah,
hypothetically
like,
speaking, yeah.
nobody even has a fax machine anymore. Anyway, so that list, it overlaps a lot with what Dr. Jane Philpott described actually in her book as well. So I wondered, I mean, how did you come up with that list of all the things that you could be talking about? These are the result of the kinds of experiences you had with your patients, I imagine.
Yeah, I mean, a lot of the book actually is stories of my own experiences in my practice, patients who I've learned from, and cases that stay with me, mistakes I've made, and small victories. And for sure, my personal experiences shaped the 6 ideas that I put in the book. And I don't claim that it's an exhaustive list, or that it's a perfect list. It is a list of solutions that I feel are within our grasp. They're realistic. They're things we actually could get done if we were to put our minds to them in today's context, in today's Canada. And they're things that are backed by evidence, because that's the other thing that I think we have to be vigilant about in this moment, is science and evidence and their importance in the ways that we not just deliver healthcare services, like what's the evidence for this treatment or this drug or this therapy or this investigation, but also in the evidence and science behind how we construct our systems. The necessity to bring evidence into public policy, so that it's not just sort of whoever woke up this morning and had a cute idea, but actually, like, what do we know? What have we learned from international experience, from studies that have been conducted? When we talk about the evidence for primary care, it is so overwhelming and compelling across time, across space, in different environments, that I feel as a person trained in science, that I can stand behind these 6 ideas. And of course, there are others. And one of the great joys, actually, of my book tour experience was the people who would stand up in the audience at the Roxy Theatre in Saskatoon, or the Public Library in Halifax, and say, you're missing. This is what idea 7 should have been. It should have been this. And in fact, I didn't talk about dental care in the book. I actually did. There is a dental care case in there, but it's not one of the 6. And so, just as an example, like, there are always people bring forward their own views. And I have a colleague, Dr. Tara Kieran, here in my department at U of T, who conducted an amazing study called the Our Care study that some of our colleagues here today may be familiar with, in which she did a really deep participatory democracy set of exercises across Canada, not just surveys, but sort of citizens' assemblies kind of approach to talking to people about what they want out of their primary care system in this country. And look, the reports just make you cry. They're so beautiful, and they induce, in me anyway, such a sense of pride and fellowship with my my sister and fellow Canadians around what it is that we're in this for from a values perspective, but also on the basis of evidence. So I think it may be that part of the conversation we're going to need to have in the last 2 weeks of the federal election and in the 4 years that come after that comes back to science and evidence. You know, we need to center. It is one of the things that can differentiate us actually from not just some of the conversations we see happening in the US, but the pushback around misinformation on social media and what we see happening all over the world in places where rhetoric is taking the place where evidence should be in conversations about how to build a society and hold a community together. It may be that that's another place we need to really think about investing time and energy.
I'm taking note, trying to think ahead. Today in the Globe and Mail, André Picard, who has built himself quite a reputation as the sort of main commentator in the media on healthcare, says our healthcare systems in Alberta and elsewhere are administrative disasters because they are devoid of accountability and micromanaged by politicians. And then he jumps ahead to say, far too often politicians are less interested in actually improving care, more drawn to fantastically simplistic and headline generating solutions, imposing their ideological views, or in the most egregious cases, financially rewarding their buddies. And he doesn't mention the name of the province of Alberta or Ontario, but and he says the answer is professional managers who are allowed to manage procurement professionally, unencumbered by political whimsy. I wonder, what do you think of what Picard said today?
You know, it's so interesting because we do tend to have this sort of allergic reaction to the word administration, and we think, oh, you know, care dollars should go to care and they should go to the front lines. And of course, that's true. But you can't run a massive system that serves every single resident of a country without somebody that knows how to run systems getting involved. And, you know, if we think about some of the pain points that we all experience in the healthcare system every day, like IT systems that don't talk to each other, or, you know, referral systems where every surgeon has their own waiting list and there's no way to know how long anybody's list is or where the next available appointment might be, or trouble incorporating people who trained outside of Canada, recognizing their credentials and getting them incorporated and up to speed in the system. Like, the solutions to those things lie in effective administration. And if anything, many parts of our health systems are under administered. You know, I was in hospital administration for 8 years before I came into this job. And, you know, during the pandemic, when beds were tight and we were worried, nobody likes to talk about pandemic anymore, but, you know, we were worried in health systems that we were going to run out of ventilators, or you had some hospitals that were massively overcrowded and others that had capacity. We survived as a health system because administrators who knew what they were doing were able to figure out how to balance those loads. Sometimes you moved staff, sometimes you moved patients, sometimes you redirected. I mean, those kinds of systems require investment and they require professional administrators. So, I mean, when I became a hospital leader, a friend of mine who's an emergency doctor said, "Oh, you're becoming a heel clicker." I said, "What's a heel clicker?" She said, "You know, those people, I hear you coming down the hall, click, 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 coming to tell me what to do." And you know, we had a good laugh. But actually, like, we do need those people. I said, you know, that's perfectly fine, and you're there in the emergency department saving lives, and we really appreciate what you're doing. And when the pipes burst and it starts raining water down on the operating room and on the millions of dollars of machines, you will be glad that there's an administrator on call, because somebody has to know how to deal with that too in order for the healthcare system to run.
So this is unlike the portrayal of the administrator that you see in hospital dramas that we watch, you know, the Pit and ER. The administrators are always horrendously terrible, only concerned about pleasing the shareholders or the board, and the caregivers are constantly at odds with them. So you're saying that really it's an alliance in effect when it's working.
It has to be an alliance. I mean, you need clinical leadership and you need administrative leadership. Somebody's got to know what's the right time to update the MRI fleet, and you don't want your clinicians having to worry about that stuff. So in well-run health systems, there's always a partnership between clinical leadership and administrative leadership, and so I do think that we want to be careful about making administration a dirty word.
So what do you think? I mean, we've heard from the leaders on a number of issues, and one of the things we've heard is that if Mark Carney becomes the next prime minister, either majority or minority, that there are going to be transfers of money, quite a lot of money to the military, and there's going to be a focus on investment and cutting spending, reducing spending, which to me sounds like a kind of a polite way of saying, get ready for austerity. He sounds a bit like Paul Martin, it seems to me, in that way. And a lot of terrible things happened in the healthcare system when the Martinites were in power. In Montreal alone, where I'm sitting, they closed 10 hospitals, 6 French and 4 English, and a bunch of people were asked to take early retirement, and the hospital system barely got up off its knees after that in that decade. So I wonder what we should be preparing ourselves for. What do you make of what we're when you read the tea leaves or reading between the lines of what we're hearing about the plans for money?
Oh, I mean, I don't know that I've got a predictive capacity on that. I guess um, I am of the view that democracy is an ongoing thing. It doesn't end when we cast our ballots, although everyone in my family will tell you I always cry when I vote because I really believe in the importance of voting. It's a very
Wait a minute, did
emotional
you
thing for
say
me.
you say you cry when you vote?
Yeah, I mean, I don't sob or anything, but I find it to be a very emotional thing. I always think about how many people don't aren't able to vote, how many women before me couldn't vote, how many people all over the world don't get a chance to, I think it's really it's not just sort of a civic duty. I think for me it's an emotional thing. But if democracy is something that happens once every 4 years, we're all in trouble, right? So I don't take for granted what the plans of any of the federal parties are going to be with respect to health spending. I think that they should and will answer to all of us, and it's for us to say what we believe the priorities need to be. I have to say that I have been heartened by the conversations going on about housing in this election. I think that that is in part a direct response to effective advocacy by all kinds of groups across the country, including people that don't often get as engaged or involved in political discourse, saying like, this is crazy that I can't rent an apartment that I can afford near where I work, or that my hopes of ever owning a home as I graduate from university are diminishingly small, or that if my parents don't have any place to pass down to me, that home ownership is essentially beyond my reach. Like, it's young people who are in many ways standing up around the importance of housing. So like, I think that we are going to have to speak up. What are our priorities for investment? Where do we think that that federal dollars should be spent? And as we approach this abyss of uncertainty that the tariff war portends for all, not just for our country, but like for the whole entire global economy, where do we see the priority needs to be, and how are we going to How are we going to make that heard? I don't think that these people make their decisions in a vacuum, and I don't even think they necessarily all know what they're going to do yet. Um, I think we've got some power.
I think I have to concur with you. I think for me, voting is very important, and I tried to explain it to my kids, both of whom are now of voting age, and we make a very, very big deal about it. But I think what you're describing is actually probably close to the way a lot of us feel about it. That so much struggle underlies the simple act of voting, going back to the English revolutions of centuries ago, the attempts of the common people to express their opinions. So, and I'm sorry to see it's fallen out of favor, like the participation rates have dropped. So it'll be interesting to see how many people show up to vote this time, because I think people are particularly more motivated right now. I just wanted to ask you, as a person in the university, what are you seeing amongst the cohorts of students that are coming through in family medicine? What are they saying about what they see in the system?
Yeah, I mean, one of the interesting things that we're seeing in family medicine is, the perception is that it's hard to access care because it's hard to get a family doctor. Therefore, we should train more family doctors. And so we're seeing big investments across the country, new medical schools opening that are quite explicitly focused on family medicine and primary care, and huge expansion of residency positions in family medicine, which is good, which we need to do. But then we see that as people complete their training and graduate, it is very hard to recruit those folks. Family doctors are, I call us the Swiss Army knives of the healthcare system. You can put a family doctor pretty much anywhere in the healthcare system, and they'll be useful. They can work in your emergency department. They can be hospitalists on the wards. They can do palliative care. They can do addiction medicine. They can practice in just about any environment you can name. And so the numbers of people who are choosing to take on a comprehensive community-based family practice and like roster 1,000 or 1,500 patients and follow those people over their life course, it's become a really tough sell. And we're even seeing it's not just new graduates, not a generational thing, among established family physicians, large numbers of people who are retiring out of their comprehensive family medicine in favor of one of these more focused practice environments. And so that the sum total of that suggests that you can't just fix the education system. You have to fix the practice part as well in order for people, otherwise we're just kind of graduating people off a conveyor belt and dropping them out into nothingness. And so as long as family physicians are spending 20 hours a week on administrative tasks, and as long as it's impossible for us to access specialist care for our patients, and as long as people are experiencing the frustrations in their daily work, difficulty managing and doing what we all went to medical school to do, which is take care of people, we are going to end up with a mismatch between, this is what we call the social accountability of the medical school, a mismatch between what we are producing and the needs of society. And so I think of this as a two-handed job. We have to do the education really well, which we do, graduate highly competent new family doctors, and then provide them with a system in which they can come out and do the work that they want to be doing, which amongst the next generation is mostly not a preference for running your own small business, hiring your own secretary, choosing your own electronic record, being on call for your patients 24/7. It looks a lot more team-based. It looks a lot more what we call turnkey. And it looks a lot more like a balanced life for these young people coming out. So that's the double work that needs to be done.
So I'm in Quebec, where almost 800 physicians have completely opted out of the public system in all ways. They do everything completely privately. paid and administered privately. People pay for credit with literally with their credit cards. They pay $4 or $5 grand to sign up to become a member of a clinic, and then they fork it over every time they go in, and they're always guaranteed to see somebody in very short order. So 800 of them in Quebec, and approximately a dozen in the rest of the country in total, in the sort of ROC, the rest of Canada. So I wonder, do you hear from young doctors who say, really, I'm looking at Quebec, I'm not sure that I want to work in the public sector? Like, do you hear any of that kind of discussion, or is it even a discussion outside of Quebec?
I mean, it's interesting because actually where we've seen a rise in Ontario, I mean, there are always these sort of boutique clinics do exist. They mostly exist in urban environments, in Canada's largest cities. So, we see them in Toronto as well. It's always been a pretty small part of the system. Where we have seen the biggest growth in the boutique primary care sector in Ontario, and which is why I was so happy to see the effective advocacy that was done by many groups, including Doctors for Medicare, that resulted in Mark Holland's interpretation letter of the Canada Health Act on this, is among nurse practitioners who couldn't get work in the publicly funded primary care system, and therefore, because of the perception of a loophole in the Canada Health Act, anyway, we see these boutique clinics opening up that are now run by NPs. And so I hope that interpretation letter will solve this issue, and we will see those precious human resources redistributed back into the public system. But I guess maybe the generous question, if one wants to be generous, to ask when we see our colleagues, whether they're docs or nurse practitioners or anyone else, opting into these boutique practices. I mean, we know why patients are doing it. They're doing it because they're desperate and they want care. As one colleague said to me, look, my commitment to solidarity and publicly funded healthcare ends the day that I can't get what I need for myself or the person I love. And so we have to make sure that the public system serves people. It can't all be our ideals. It's got to actually be effective at giving people what they need. And if you look at the work in these boutique clinics, it is slower, it is more time per patient, it is a smaller caseload, it is more time spent on prevention and wellness, all of which we would all like for ourselves. I mean, I don't want the unnecessary and inappropriate testing myself. I don't want to be subjected to things that I don't need or that could cause me harm. And I don't want to be sold stuff that isn't going to help me be healthy. But, we all want same day access, and we all want the ability to email with our doctor, and we all want a person who's not just going to see us when we're sick, but help us to stay well. And so I take up the challenge. We all deserve that, actually. And the question is, why is it so hard to deliver it in the day-to-day busy primary care practice? And we have lots of examples of amazing primary care happening in the public system. We need to build on those examples rather than, I'm not for scolding, I'm for recruiting back. I want those people to come back. I want them back in our healthcare system, taking care of everybody, not opting out to take care of only the people who can afford these outrageous fees.
To the point where they have ads on the sides of buses and on billboards, some of these private clinic operators here in Quebec. Anyway, so Mary Findlay on the Q&A. I would just invite people, if you have a comment or a query, just to jump on the Q&A. So Mary Findlay's asking how you see the idea of the scope of practice for nurse practitioners potentially becoming homogenous across the country, sort of in connection to that letter from Mark Holland, the former health minister. And then Steve Staples, our colleague here at the Health Coalition, is asking, with Trump's 51st state threats, is this an opportunity to remind Canadians about the differences between Canada and the US health system? What are the obvious differences for patients? So there's two questions for you, Dr. Martin.
Sure. So, I mean, on nurse practitioners, like, nurse practitioners are highly competent, amazing healthcare workers. I work alongside some excellent ones in my own practice. And I think there's a tremendous role for them in primary care. And like all of us, including doctors and everybody else, I think we all work best when we work in teams. And I can't imagine, for example, working without the pharmacist I work with on my own team, who does unbelievable work, particularly for our older patients who take multiple medications. So, I think that the future is not about any one healthcare provider. There is so much work to go around. In primary care, just on sheer numbers alone, almost all primary care in Canada is delivered by family physicians and will be, until future notice. But that doesn't mean that we don't want to embrace and uplift the scope and the role of NPs, pharmacists, social workers, nurses, dietitians, everyone. Look, it's going to take all of those folks. And actually, that's the only way that we are going to get to full attachment, to 100% of the population being attached to a primary care practices by working in teams. So I think the question is no longer what should the scope of any individual provider be, or the role of any individual provider. The question has now got to be, how do we configure the team in the best possible way in order to achieve 100% attachment of the population and excellent access? Because as many Canadians will tell you, it's all very well and good to say, yes, I'm attached. I have a person or a team that I can point to and say that's my person or team. But then when I call to try to get an appointment, I can't get in for 8 weeks. That's not what we're going for here. And so what is the configuration of team, and what are the roles that different team members need to play in order to get to full geographic attachment and ensure that there is timely access? That's going to be the dance, and different teams are going to figure that out differently, and the role of the NP or the nurse or the family doc or whoever it is going to depend on how many you've got, what the needs of your population are, and how you're going to, put it together with paper clips and duct tape to make it work for your local community. There's not going to be a single answer to the role or the scope. And sorry, Steve's question was about the 51st state threat.
Yeah, potentially reminding Canadians about the differences between Canada and the US.
I mean, this is sort of, yes, I agree with you, Stephen. I think that I think this is what I was trying to say, is that I decline this setup that we might create for ourselves, in which it's like economy and sovereignty against health and social services. Like, actually, Medicare is one of the great nation building projects in the whole history of Canada. So if what we care about is sovereignty, both economic and spiritual, if you will, then sovereignty of values, and not only sovereignty of fiscal and monetary policy, then healthcare and social services, education, income supports, housing, climate. These are the nation building questions, topics of our time. And yes, I think we should be unashamed to leverage them for the nation building moment that we seem to find ourselves in. We've been handed a nation building moment. So what will we make of it? I think that health and healthcare could figure quite strongly in the answer to that question.
Jerry Pearson, asks about the role of physician's assistants. I don't think I even know what that is. What is a physician?
Yes, we have a physician assistant training program in my department here, in partnership with the Northern Ontario School of Medicine University. So physician assistants, which are another flavor of healthcare worker, newer on the scene in the Canadian context than NPs, but these are advanced practice professionals who tend to work more in partnership or alongside a physician. They have less independent scope of practice, but tend to kind of we use the word extend the capacity of the physician. So you may see one in an emergency department, or increasingly perhaps someday in a family doctor's office or a primary care team office, doing tasks that would be traditionally done by a doctor or a nurse, but they're under the supervision. They function under the license of the physician, and we're going to need them. They're terrific. They're well trained, and we're going to need PAs. We're going to need NPs. We're going to need community health workers. We're going to need all these and more that we haven't even come up with yet in order to deal with the human resources demands on a healthcare system that is not adequately peopled, and that will need to be even further peopled as the population continues to age and the demands on the healthcare system get greater.
Dr. Martin, what would you say to somebody who might be on this call, or somebody who is an acquaintance or friend or relative of somebody on this call who cannot get primary care? What are they? How are they supposed to do that? Should they be trying to pull strings? Should they be lining up in queues on the mornings on Monday mornings to see if they can sneak it? Like, what are people supposed to do in the meantime?
The answer to that question, and this is such a Canadian answer, but it's true, is like, it depends on where you live. And so truthfully, many, but not all Canadian provinces have, central wait lists that you can sign up for in order to get in the queue, and people are prioritized according to medical need. Oftentimes people will have luck through a family member who has a family doc asking, would you take my, it's pathetic that we have to have these conversations. This is Jane Philpott and I have both used this analogy many times. Like, imagine if I moved into a neighborhood and I have a kid who needs to go into grade 3, and I had to ask around if anybody knows of any teachers who are taking grade 3 students, or like go around and beg the principal at my local school, like, please, will you take my kid? I promise they won't be any trouble. Or, put my child on a wait list that might be years long in order to get into grade 3. Like, that would never happen. If I move into a neighborhood, my kid has a right to go to the local public school, and that's it. And if that teacher gets to 28 kids or whatever the maximum is, 30 kids in their classroom, we don't just yell more loudly at the teacher that they should take more students. We open another classroom. We usually put a portable in the freezing cold schoolyard. We build another school if necessary. We expand the capacity of the system to meet the needs of the neighborhood. And so we can't just yell more loudly at the existing healthcare workers that they should take more, see more, do more. That's not going to work. We need to build the capacity to absorb the needs of the population. And in the meantime, people are doing all kinds of things. They're going to walk-in clinics. They're going to the emergency department. They're just not getting care at all. They're, as you say, pulling strings, making calls, asking anyone they know. And it's not just, it's not right. It doesn't feel good to anybody. And so we definitely need to move to a system that is more organized and supports people to get the service that they need, but also supports the people working in the system to be able to effectively deliver it.
So your analogy between healthcare and the school system is one that Jane Philpott explained to us at our research symposium. And I see Steve has inserted a comment along those lines about Ontario moving forward with Jane Philpott's plan to deliver care through teams based on a patient's postal code. And it actually seems to be happening in Ontario under Doug Ford.
Yeah, we're on the journey. We're not there yet. Jane was only appointed, I think, about 30 seconds before they called the provincial election, but it will happen. I believe it will happen. I have to say, I feel very hopeful, very optimistic. For the first time in my career, I've been a family doctor in the healthcare system in Ontario for 20 years now. And for the first time, this is at the top of the political agenda. And I think it's because the politicians, no matter the political stripe, are really tired of knocking on doors and having people say to them, "What are you doing to get me a family doctor?" It is because they have heard it, you know, in the lineups and at the Tim Hortons and at the political rallies and from their constituents, that they have come to realize that this is an issue that needs to be addressed. And that creates a window of opportunity for us to build like really a proper healthcare system from the foundation on up.
I feel like we're very lucky in Canada to have so many wonderful physician tribunes, you and Dr. Philpott and the physicians and Canadian Doctors for Medicare, and in the equivalent group in Quebec called les Médecins Québécois pour le Régime Public, who do really good work here, in addition to all the people who work on the health coalitions across Canada, the provincial and territorial health coalitions. We are really lucky to have so many brilliant people paying attention and coming up with ideas, and yet we don't hear, I don't think we hear it resonating enough in the old line parties, in the political class. And I guess I'd like to just close on the theme of the election, which we're halfway through. So we're about 2 weeks away from the end of this very unusual election that can only really be compared to the election in 1988, the big free trade election, all those many decades ago. I wonder, what would be your closing message to attendees today and to anybody who'll be watching? Because we're going to post this webinar on YouTube, so you'll continue to live on the internet, Dr. Martin.
I mean, I think for me, it is, I'll close as I opened by saying, I really do think that this is an election about health. That if we don't secure the economic well-being of people, we cannot secure their health. And if we don't put in place those essential building blocks, like safe housing, public education, et cetera, we can't even begin to have a conversation about healthcare. But once those fundamentals are in place, it will be up to us to make the case for whichever party is elected, that the way to build the nation, this Canadian project that we are in, begins with our public healthcare system, with its securing its expansion, and with the values that it represents for Canadians. And I believe that will catapult all of the good work that we've all been engaged in, whether it's pharmacare, whether it's dental care, whether it's protection of the Canada Health Act, whether it's improved care for elders in the community. You know, these very important questions that we care about in the granular places of the healthcare system represent a nation building exercise. And that is what we are going to have to convince our political leaders of. And I don't think that we have to do it just in the next 13 days. I think we've got time to make that case.
I just wanted to close with a comment from an anonymous attendee who says, "I'm very pleased to hear Dr. Martin's viewpoints. Thank you for leading and caring." And I think that's actually the perfect element to say goodbye on. And we hope that we will talk to you again soon. And just in closing, also, I'd invite attendees to take a look at our election hub. We prepared a bunch of documents for people to call through, and we've even enabled you to be able to use some of those electoral tools, because like Dr. Martin, the fact that we have a chance to vote means that we have a chance to express our opinions through a little mark on a piece of paper, and it's an absolutely wonderful thing to be able to do. So thank you once again for joining us today, Dr. Martin. We really, really appreciate it. All the best.
Thanks so much. Thank you for having me, and thanks for the important work you do.
And you. Thank you so much. And thank you to everyone who attended. We know that you care deeply, and we're with you, and we hope to talk to you as well again soon. So take care, everybody. Bye-bye.